everybody. I don't think anyone has joined us yet, so maybe I will just give this a minute until I see a couple of viewers, and then I will start with my introduction. Oh, just kidding. Now I can start. Okay. Let's see. Looks like no one has joined us yet. And oh, hi Natalie. I do have a few viewers. Excellent. Okay, so I will start with my introduction, and some of you may know me, some of you may not. My name is Jess Hebert. I am one of the registered midwives at Midwifery Collective of Essex County, and welcome to Ask the Midwife. For those of you who have not joined us before or who are not familiar with our practice, Midwifery Collective of Essex County has offices both in Windsor and Leamington, Ontario. We service the population of Windsor and Essex County, and we consist of 6 midwives, 5 of whom do primary care, which means we take care of women through their pregnancy, labor, delivery, and for the first 6 weeks postpartum. And our practice owner, Andrea, is a lactation consultant and a midwife, and she runs a program called Expecting and Connecting, which specializes in breastfeeding support in the postpartum period for all women, whether you have had a midwife or an OB, and especially if you are looking for that extra breastfeeding support that she provides that. Before I get started with any information today, I do want to say that this is not meant to be medical advice, but for educational purposes only, and that if you do have any health concerns, whether you are pre-pregnancy, in your pregnancy, or in your postpartum, please ask those health concerns, or please address those health concerns with your primary care provider, whether that be a midwife, a family physician, or your obstetrician. Okay, so let's get started tonight. What I'm going to be talking about from now until 6:30 and answering questions about is some of the differences between midwife care and OB care. So I would like to preface this with the obvious bias that I myself am a registered midwife and that my primary experience is providing care as a midwife. However, as a midwife student, we all do a placement with an OB, and while that is only for 1 month, we are exposed to what care kind of looks like with an OB as we get to be involved and participate, either like doing discussions, but also doing observation of OB clinic, OB deliveries, and just OB management in general. And we get to learn about the OB perspective and also about issues that are not in our scope, but about things that we would be consulting and transferring care for once we do become midwives. So the other piece that I'm going to be drawing, the other place I'm going to be drawing information from, not only from that placement from my student years, but also from some of the feedback that I've heard from clients over the years where they have had both a midwife and an OB either in the same pregnancy or in different pregnancies. Okay. So first and foremost, probably the biggest difference that I find between a midwife and an obstetrician is the scope of practice. Midwives are experts in the normal. We care for low-risk, normal, healthy women, low-risk pregnancies, low-risk babies. That is our expertise. And while we have it in our training to understand and to identify high-risk issues, it is not in our scope to medically manage those issues. However, it is in the obstetrician scope. The obstetrician scope of practice is higher risk. Again, they have the expertise to manage low-risk pregnancies, but their expertise really lies in the higher risk pregnancies. So for example, when we have a patient we as a midwife have a patient who is low risk, we don't have any clinical concerns, their clinical care is all within our scope, we do not need to involve an obstetrician in their care. We are able to manage that care by ourselves as midwives, as that falls into our scope completely. And that counts for pregnancy, for labor, birth, and the postpartum, in addition to being an emotionally supportive care provider. We're also a clinician, and at the end of the day, that we're looking at that entire clinical picture. We're ordering tests through pregnancy, we're interpreting those tests, and we're following those results up as needed. And that is both for mom and for baby. And when we encounter a clinical issue that is outside of our scope, that is when we would involve an obstetrician. And whether that is in consultation or in transfer of care, and in both of those situations, the midwife would remain involved in that patient's care, just in different capacities. That when we have an issue that is outside of our scope, we want to involve the obstetrician so that we can use their scope and that they're able to either manage that issue or take over medical management of the pregnancy. Because again, when something is out of our scope, we want that issue to be managed by the most appropriate person, which in some cases is the obstetrician. And I always find that sometimes there's a little bit of confusion as to, well, if an OB can do everything and a midwife can only do some things, then why wouldn't everyone go with an OB? And that's a really great question. And a big part of that reason is that because midwives have the luxury, I think it's a luxury, the luxury of being experts in the low risk and normal, then what we get to spend a lot of our time doing is, instead of managing high risk situations like the OB has to, because that is their job, that is their expertise, that's what they're trained for. They are not only physicians, but they're also surgeons. They do C-sections, they do all those high risk pieces. Because we don't have to worry about those pieces in our scope. We have time to spend longer with our clients as midwives. And what that means is that we have a lot of time for prenatal education. We can spend time talking about all the different pieces throughout pregnancy, all the different tests, what all the different you toward what research is good to look at, help you figure out where to find that research, and just be able to spend that time having those conversations, doing those chats. On that note, our appointments with our patients are usually about a half an hour long, half an hour to 45 minutes, depending on the situation. And compared to OB appointments are usually, at least in the experience that I have, again, from what clients have told me, but also from my own experience doing my OB placement as a student, the appointments were about 10 to 15 minutes long. Really enough time for clinical care. And then what I have heard from clients, that sometimes if there is a concern that needs more discussion, that maybe that would happen at a separate appointment that's specifically booked for that. But I do find that because obstetricians have a higher caseload, which means that they have to take on more patients than midwives do, again, we have the luxury of not needing to take on that many people. The way that we're funded allows us to take on a certain amount of people so that we can spend a lot of time with each one of those people. And the way that that OBs work is they do have to take on a lot of patients, which means that the trade-off for them is often that they don't get to spend as much time as they may like to with each patient to be able to do those clinical education pieces, those prenatal education pieces, which is why for lots of patients who are going with an OB for their prenatal care, that they may do a prenatal class and find that super helpful, whereas if you have a midwife for your care, you may do a prenatal class but not find it as helpful, because you might find, oh, my midwife has already been able to talk to me about this in our prenatal appointments, because like I said, we really have the luxury of time to give to our patients. And with that, we not only do we have time to talk from our end, but we also give you the time to talk from your end, and ask questions and be able to answer your questions. And I know for myself and for my colleagues that we sort of have like not a policy, but sort of a rhythm in our clinic, that if we're finding that our appointment is taking longer than that half an hour and you have more questions, then what we tend to offer is, you know what, let's make a phone appointment for the next day or a few days from now when we can actually have that conversation without feeling stressed about the time. And again, because of the way that our schedule works, because of our lower caseload in comparison to an OB, we just have that time to give to all of our patients, and especially those who need it. No matter what pregnancy it is for you, there's always something new to learn. Every pregnancy can be different. Every labor and delivery can be different. Every baby is different. So there's no such thing as a silly question, and no matter how many babies you've had, one thing that I always try to do well is always open that room for questions, hear your questions, and try to answer your questions to the best of my ability. And as we go through our chat tonight, if you do have questions, please feel free to type them into the comment box, and I will again do my best to give you some answers. So I've talked a little bit about differences in scope of practice, midwives being kind of our scope is low risk versus the OB scope is high risk. And I mentioned a little bit before that, let's say you're in care with a midwife and everything's low risk, low risk, low risk, but then suddenly there's a high risk issue, that we don't just hand you off to an OB. What that would look like, depending on what is going on, sometimes we just need to have a consultation with an OB where the OB would work with us on one specific part of that care and then not be involved in the other part of your care. Another version of obstetric involvement when you have a midwife is that we would transfer your care to the OB, which means that the medical management of your care would be done by the OB, but you would never lose your midwife unless you didn't want midwives anymore. So what that would look like is called supportive care. And what that means is that while the medical decisions would be being made by you and the obstetrician, the midwife would stay in support. You would still see us, or at least have phone appointments with us. We could still be present for delivery for support. We can still do your home visits, help you with breastfeeding if that's what you're planning, take care of your baby. The baby would still likely be able to come into us. Again, it would depend on the clinical situation, and we would talk about all of those things if this was a situation that you found yourself in, being in midwife care with an OB involved as well. And we would just make the best, safest plan for you and your baby, with trying to give you all the support that you need and to give you the best experience possible. I mentioned at the beginning of the video that our practice owner, Andrea, runs a program called Expecting and Connecting through our clinic as well. And sometimes patients who are absolutely too high risk for primary care with midwives, that they have to start their pregnancy under an OB and remain under the OB completely. Expecting and Connecting is a wonderful way that patients who absolutely have to be with an OB can still benefit from midwife support, and in particular breastfeeding support and home visits as well. And that is all part of the Expecting and Connecting program. If you are wanting to know more information about Expecting and Connecting, midwives in general, and our practice specifically, please visit our Facebook page. You can also visit our website, midwiferycollective.ca, and also you can call our office at 519-252-4700. Our phone number is on our Facebook page and our website as well. If you Google Midwifery Collective, we will come right up. Let me have a quick check and see if we've got any questions so far. Not yet. That's all right. What else can I say about the differences between midwives and OB? Oh, I know. One thing that I get asked a lot, or one thing that gets commented a lot from clients who have had either midwife, like an OB in a previous pregnancy, or midwives in a previous pregnancy, and sometimes they're just curious, is what is the difference between, like, who could be there at delivery? So the way that it works in our community in Windsor, Essex, excuse me, in Leamington, there are 2 obstetricians that work out of that hospital. So whichever OB, let's say, that you are having your primary care with, it could be either one of the OBs that are called to your delivery, depending on who is on call the day that you deliver. And in Windsor, it works relatively the same way, except instead of 2 obstetricians practicing out of Windsor Regional Hospital, there are more than 2. I want to say somewhere between 8 and 12. I'm sorry that I actually don't know the exact number in our community, but the principle is the same, is that regardless of which obstetrician is providing your care, whichever obstetrician is on call on the day that you deliver would be the obstetrician managing your labor and delivery, along with the team of nurses. We, the midwives, also work with the nurses. So when you are in care with midwives, it's similar in the sense that it could be any one of us, whoever is on call, to come to your delivery. But because there are only 5 midwives doing primary care, what we try our best to do is to have everybody meet all the midwives at least once, so that no one is a stranger, and whoever shows up will be at least a somewhat familiar face. Beyond that, the other thing that we do in our practice is that we split ourselves up into 2 teams. We have Team Blue and Team Yellow, 3 midwives on Team Blue, 2 midwives on Team Yellow, and we assign those colors to our clients as well, so that it sort of becomes more likely that the same color midwife will be called to the same color. So if you're a yellow team client, more likely you would have one of the yellow team midwives, and vice versa for blue, just to try to get a little more of that continuity. Again, it comes back to the caseload issue that not only do OBs and midwives alike really, we would love to catch all the babies of our kind of personal patients, but in order to have a good work-life balance for everyone, and as much as this is all patient-centered care, the flip side, or the other side of this story, is that we also have our families, and we have our work-life balance to think about as well. So the trying to split up that call schedule fairly so that everyone has their turn on call, everyone has their turn off call, everyone has time on and off work, and to make sure that everybody ultimately gets appropriate safe care is everybody's goal. So when you're in OB care, because you see one OB through your whole pregnancy, and then when you deliver, it's just whoever is on call would be the managing OB of that labor and delivery, there is a higher chance of having an OB that you have never met before. But that is not necessarily a bad thing. Again, all of the obstetricians are there with the same goal in mind. Happy, healthy mom and baby. That's what we all want. We all want everyone to have good outcomes. But on the flip side with midwives, the comparison is that you do have a much higher likelihood of having someone that you have at least met once, someone that you know at your delivery. So that's also one of the bigger differences. And again, that's not something that is kind of a good or bad thing. It really just is the way that it is to make the system work well, to keep that goal of safe care in mind for everybody. Still no questions. I am more than happy to take questions, everybody. So if you do have some, please shoot. If it's not about this topic, if it's even about midwives in general, please feel free to ask. I'm happy to shift conversation a little bit. Or if you joined us late and you had a question about the differences in scope, I'm happy to kind of rehash some of that information. Another great place to find information about the scope of midwives is our college website, so the College of Midwives of Ontario, and that is actually the college that every midwife is in Ontario, every registered midwife is registered with. There's information about what a midwife is, how we work, etc. You can also find that information on our association, our Association of Ontario Midwives website as well. I can post those. In our chat if you guys are curious. But if you have Google, and obviously everyone watching has some internet access, you can, if you just Google Association of Ontario Midwives or College of Midwives of Ontario, then those websites will come up, and there's lots of information about midwifery in Ontario. In terms of like midwife care versus OB, I don't really love the terminology of versus, because there's really not a better or worse option. It really depends on what is right for you, both what feels right, how you think it's going to, how you think it's going to make you feel to either be cared for by an OB or by a midwife. But during pregnancy, in terms of the care provided, even though our scope is different, all of the routine, basic standard of care, that is not different. Midwives and OBs see patients on the same schedule. We order the same tests. We do the same things. We talk about the same things. And where it really depends on what's going to make that difference is if clinically there are concerns whether or not obstetric involvement is warranted in that person's care. And like I said, if that is warranted, then once you're already with midwives, you're not going to lose your midwifery care unless you don't want midwives anymore. So I really don't want to get into like a better or worse, because it's just not really that kind of issue. It's really about what is right for you, both emotionally and then both clinically speaking as well, depending on the complexity of your medical issues. Over 90% of pregnancies are healthy and normal, and that is right in my scope as a midwife, and that is who I love to care for the most. it's really lovely, not that I don't love working with the OBs, but it's actually lovely to just be able to monitor normal low risk pregnancy, see that person through her pregnancy, labor, delivery, 6 weeks postpartum, and just watch that physiological process unfold. That being said, because we are clinicians, part of our job is that monitoring, and that we are always going to be looking for, is everything okay? Are we remaining within that box of normal? And if we're stepping toes outside of that box of normal, then that's going to change how we manage your care and how what recommendations we're making, whether that is, if we're at home managing a labor, maybe that recommendation is, we should transfer into hospital. If it's prenatal and an issue comes up, maybe that recommendation is maybe we should involve an OB. But regardless of that recommendation or that change of plan, no matter what that is, as long as there is time to discuss it, then we're going to tell you what our concern is, talk about it, tell you our plan, and then we're going to ask for your feedback, ask for your questions, and go from there. And again, like I said, this is just sort of general information. Of course, I'm not speaking about any particular clinical case. We definitely look at just like an obstetrician, we look at every case individually. We practice patient-centered care, and we make the best plan per person on that individual basis, looking at your specific clinical picture, yours and your baby's. Let me see. Oh, that's a great question. Okay, good. I have a question I'm happy to answer. So question from Jillian. She's asking if I can discuss the difference between induction with a midwife versus an OB. And let me start by saying again, depending on what the clinical indication for induction is, that might look different. But let's use an example of an uncomplicated person who is being induced because let's say they have been with midwives for their whole pregnancy, there has been no issues, and they're being induced because their pregnancy is now past or at 41 weeks gestation, at which time the research says is an appropriate time to either continue the pregnancy for 1 more week with monitoring or consider induction, and maybe the plan for this person is induction. When in this case, and in other clinical circumstances, well, really as long as there isn't a big clinical concern, and if there was, your midwife is going to talk to you about that beforehand, but as long as there isn't a big clinical concern, or as long as the care hasn't already been transferred to an OB, midwives in our community it's part of our scope and have the skills to run an induction. And what we always do when we start an induction, we always do a consultation with the OB, and that is to review the case and also to get the order for the oxytocin if we're using oxytocin. Induction can go a couple of different ways, again, depending on the clinical situation. So this depends on what your cervix is like, how low your baby's head is, whether or not your waters are already broken. So for myself as a midwife, depending on whether the baby's head is low enough, sometimes what I might want to do is only try breaking a person's water. And sometimes when you artificially rupture someone's membrane and break the water, sometimes that can start labor in and of itself. But sometimes that doesn't happen. And sometimes the baby's head isn't low enough to safely do that. So we need to use a little bit of the medication called oxytocin or Pitocin. Oxytocin is the same hormone your body makes in labor to cause contractions. Sometimes we need to use a little bit of that through an IV to get contractions started, to bring the baby's head down, to then safely rupture the membranes. Depending on, regardless of what kind of clinical way we're starting that induction, as long as your care is staying with the midwife, then really the biggest difference between an induction under an OB and induction under a midwife is that your midwife is going to be the person doing your vaginal exams, running your oxytocin, breaking your waters, monitoring your baby, doing your vitals, doing all of your labor assessments and being with you through your labor, and doing the combination of your clinical care and your labor support. Under an OB, the OB would be doing those exams and kind of making those decisions as things progress, and the nurse would be doing exams as well, would also be doing your labor support, monitoring your baby, doing your vitals, monitoring you, etc. And then if the nurse had any concerns, she would be reporting that to the OB. The OB may come in for assessment, and the OB would be discussing those plans with you and with the nurse. Versus with a midwife, the midwife is assessing and making plans as she sees fit, and if the midwife has concerns, then she would involve the OB further in the labor, depending on, again, what that concern would be. I often get a question of, if I'm being induced with a midwife, does that mean that I won't, like, you won't have to use oxytocin at all? And that's not something that I would ever guarantee. Like I said, it depends on a lot of clinical factors, and ultimately what we want to do is the best plan to have the best chance of an uncomplicated, successful vaginal birth. Anytime we are doing an intervention, including even breaking your waters and or using oxytocin, anytime we do an intervention, there's always the risk of more intervention. So whether you are with a midwife or an OB, the recommendation would be, if we're having an induction, that take place in the hospital for increased monitoring, and also, again, for that intervention risk, that if we do need to do anything more, we're already in the place with all of the resources handy. That being said, even after an induction, with an uncomplicated delivery, if there are no concerns in the immediate postpartum for mom or for baby, then what we do as midwives, and this is actually kind of leads me into another good difference between OB care and midwife care. Because midwives, it's part of our scope to follow moms and babies in the community. We do home visits. We see you either at home or in the hospital day 1 postpartum. We see you at home day 3 postpartum. We see you at home again between day 5 and 7 postpartum. Because that is just part of our normal schedule and our routine care as midwives, we're able to offer an option of early discharge, which means going home from the hospital before 24 hours for parents that feel comfortable with that decision, who want that decision, and who are cleared clinically by their midwife. So what that means is that instead of needing to stay in hospital for 24 hours in order for the baby's newborn test to be done after the 24-hour mark, because they can't be done before the 24-hour mark, that if you have a midwife, and as long as delivery went smoothly, there's no concerns, I can't stress that enough, then what we offer our clients, what we offer our patients, is to go home before that mark. Go home to your own bed, breastfeed in your own room, in your own space, and then we can come see you at home after the baby is 24 hours old and do the newborn screens from home. So you actually don't have to go back to the hospital at all. The only reason you would have to go back is, again, if we came over, assessed you and baby, had a clinical concern, and then a clinical concern that warranted hospital assessment, then we would have to organize that, and then we would absolutely do that. But otherwise, we assess you, we assess baby. The other thing too, another difference between midwife and OB is that we have, OBs are on call. There's always an obstetrician on call in the hospital, but they are in the hospital. Versus midwives, we are also on call 24/7, 365 days a year, and we all take turns being on call, but you're able to call us day or night, and you're going to talk to one of the midwives that hopefully you know, but at least one of the midwives for sure. And then if you did need an assessment, that midwife would assess you either at home or in hospital, depending on what the issue is, whether you're pregnant or in the postpartum, and that midwife would just make the best plan for you at that time. And so that's one of the other differences versus with an OB. If you did have an urgent concern, you can always call OB triage and speak with the triage nurse. Excuse me. But ultimately, if you did have a concern, you would have to present to OB triage to be assessed. And sometimes in pregnancy, sometimes we have concerns, and then we speak to a midwife, and it turns out, oh, you know what, we actually don't need to be assessed right away. We can give it some time. Midwives are all skilled and trained in phone triaging, so we know specific questions to ask. So over the phone, sometimes we can determine whether or not we need to bring you in, and we can do a little bit of that extra education, and sometimes it actually saves people an unnecessary trip to the hospital. So it's really nice to be able to do that as well. And it's much harder to do that as an obstetrician because they have to be in-house in the hospital. So I don't know a lot about being able to call an OB office to speak with an OB in that way. I don't know a lot if that's even an option, but I know as a midwife that you always have access to our urgent pager when you're in our care. And then for anything urgent, you would call that number. Then anything non-urgent, we do instruct people to call our office and speak to a midwife non-urgently. Okay. Any other induction specific questions, or Jillian, did you get some information from that? And then Jillian, if you are in midwife care, I encourage you to discuss with your midwife for your specific clinical situation. If you are either looking to become pregnant or just kind of curious, and I hope I did answer questions, but please feel free to ask more specific questions. We're just at 6:30 now, so I'm just going to give everyone about like 5 more minutes if anyone has any last minute questions. But I think I did cover quite a bit. Please feel free to post on our Facebook if you want some more clarification of differences between midwife care, OB care. Like I said, check out the Association of Ontario Midwives website, check out the College of Midwives of Ontario website for some more information about midwifery scope of practice and what routine care with a midwife looks like. And feel free, like I said, to post questions on our Facebook, and then that will also help us include that information in future Ask the Midwife videos. Once again, as a disclaimer, this is not medical advice, but for educational purposes only. And our next Ask the Midwife is going to be with our registered midwife, Abby, and that's going to be in 2 weeks on August 25th at 6 p.m. So please ask your final questions now, and I will get ready to sign off after I answer maybe one or two more if anyone has any. Oh, hi, Anna. Sorry, I didn't see your comment earlier. Hi, everyone. So nice to see some past clients in the audience tonight. So nice. I hope everyone's doing well and staying safe and trying their best to keep busy in these times. Hopefully now that things are starting to open up a little bit more, that we can all do some more things besides staying at home as things become safe to do so. Natalie was just, I don't know if everyone's reading the comments as they come up, Natalie was just mentioning that she really enjoyed being able to be discharged from the hospital before the 24-hour mark, and I get that comment all the time. Even for moms who are wanting hospital birth and not home birth. Again, Choice of Birthplace was the first Ask the Midwife video that I did about 6 weeks ago now, and everyone should make that choice for themselves and choose wherever they feel the safest for sure. But a really nice thing to be able to offer is to still have that hospital birth but not have to stay there when it's not clinically necessary. And I really love being able to provide that for our patients and really get people back home where the family belongs. When there's a healthy mom and a healthy baby, it's time to go home. That being said, sometimes everything can be healthy, and you can also choose to stay. No one's going to kick you out of the hospital, okay? If you want to stay that 24 hours, especially maybe if you're a first-time mom, you want that, the nursing care for that first 24 hours, that's also fine. No one is going to, again, like I said, no one's going to make you leave. But it's just an option that we're able to offer when things are uncomplicated. All right. Well, I will say my official goodbye then, and thank you so much everybody for joining me for Ask the Midwife number 7. Like I said, please feel free to add questions if you didn't feel like they were answered, or if you want something to be answered in a future Ask the Midwife. Our next Ask the Midwife is going to be on August 25th. And once again, I'm Jess Hebert, one of the registered midwives at Midwifery Collective Essex County. If you are interested in midwife care, please look us up online, midwiferycollective.ca, or call our office. Our information is on our Facebook page and our website. And I hope that you will all join us again. Abby's topic is to be announced, so keep an eye on our Facebook page for seeing what she will be talking about in 2 weeks on Ask the Midwife number 8. Have a lovely evening, everybody. Take care.